Thank you all for joining us at the Warfield Center at the University of Texas at Austin for the second in our Critical Conversation series. I wanted to invite all of you for a conversation about the current pandemic, the COVID crisis. And I wanted to have this conversation. I was sparked in part by the early claim that a number of elected officials and public health officials made early on that COVID-19 did not discriminate, that the virus didn't care if you were Black or white or Asian in the United States or Italy, Republican or Democrat. And while the virus may not care, it does seem from the statistics that we have so far that how societies are structured matters and how rates of infection spread demographically. And in this sense, it would seem that in the US, all the other problems with the Trump administration's response notwithstanding, that we are seeing a disparate impact of the coronavirus on Black people. These are statistics that I was able to pull from the internet just yesterday. And so you can see in the case of Illinois, with just over 11,000 cases, 29.4% of those who are diagnosed are Black, and 41.2% of the deaths have been by Black people. In Michigan, it's a similar statistic. It's just short of 16,000 cases, 35% are Black compared to 25% for white, but Black people are also accounting for 40% of the deaths, where whites are accounting for 26%. And this is where the structures of the society and the problems that have plagued the US in terms of race really come into focus, where a quarter of the cases and a quarter of the deaths are in Detroit, which is 80% Black. And then in New Orleans, we see a similar situation, where in Louisiana overall, just over 13,000 cases with 477 deaths. And they don't have racial statistics, the breakdown for Louisiana, but 40% of those deaths are in Orleans Parish, where 60% of the population is Black. And so in seeing these statistics, I quickly grew leery of the idea that this is something that will impact everyone equally. But I also recognize my own limitations to speak about this and to talk about this coherently with my limited familiarity with public health and infectious disease and epidemiology. So I want to thank the three of you for coming on, scholars of race, technology, public health, and the history of race and science. And so we are joined by Deirdre Cooper Owens, who is the Charles and Linda Wilson Professor in the History of Medicine and Director of the Humanities in Medicine program at the University of Nebraska-Lincoln, where she teaches on the history of medicine. Dr. Cooper Owens' first book, Medical Bondage, Race, Gender, and the Origins of American Gynecology, which was published in 2017 by the University of Georgia Press, won the 2018 Darlene Clark Hine Book Award from the Organization of American Historians for the best book written in African American women's and gender history. Dr. Cooper Owens is also the director of the program in African American history at the Library Company of Philadelphia. Currently, she is working on a second book project that examines mental illness during the era of United States slavery, and is also writing a popular biography of Harriet Tubman that examines Tubman through the lens of disability. We are also joined by Dr. Samuel Kelton Roberts, who is Associate Professor of History at Columbia University. He's also in Socio-Medical Sciences at the Mailman School of Public Health at Columbia University and African American Studies. He is a former director of Columbia University's Institute for Research in African American Studies and is a co-founder of the National Black Harm Reduction Network and serves on the boards of the Alliance of Families for Justice and the Legal Action Center. At Columbia, Dr. Roberts leads the research cluster for the historical study of race, inequality, and health. He is also the host of the Public Health and Justice podcast, PDIS, People Doing Interesting Stuff. and currently is writing a book tentatively titled To Enter a Society Which Doesn't Want Them: Race, Recovery, and America's Misadventures in Drug Policy. And we are also joined by Ruha Benjamin, who is Associate Professor in the Department of African American Studies at Princeton University, where she works on, where her work studies debates about how science and technology shape the social world and how people can, should, and do engage technoscience, grappling all the while with the fact that what may bring health and longevity to some may threaten the dignity and rights of others. Dr. Benjamin's first book, People, Science, Bodies, and Rights on the Stem Cell Frontier, published in 2013 by Stanford University Press, investigates the social dimensions of stem cell science with a particular focus on the passage and implementation of a quote unquote right to research codified in California. Her second book, Race After Technology, Abolitionist Tools for the New Jim Code, published by Policy Press in 2019, examines the relationship between machine bias and systemic racism, analyzing specific cases of discriminatory design and offering tools for a socially conscious approach to tech development. So again, thank you all for agreeing to come on and have this conversation. And I want to begin just by asking how each of you are doing and how you're holding up and how your families are in this moment.
Thank you for having me, Minkah. I am well, thankfully. I am in Nebraska, which until about a week and a half ago hadn't experienced any deaths. So it's actually one of the safest states to be in. And our medical center in Omaha is consistently ranked as one of the best for these kinds of epidemics and pandemics that we've experienced. So in a kind of regional way, I'm good. But in terms of family, I have close friends, unfortunately, who are battling this virus. Some have pulled out successfully, and there are others who are still awaiting what will happen. So it's a scary time for all of us, because the one thing we're certain about is that it's uncertainty.
I'm all right, thank you. I'm in New York, so I guess I'm at the opposite end of the spectrum. As of this moment, April 6th, we're in the epicenter. So we're just waiting for it to pass over.
And so I guess that means I'm in the middle, here in Central Jersey, and, trying to watch my media diet in terms of how much I consume from mainstream media, from Twitter feeds, and also trying to stay connected to loved ones, community, through all the virtual ways we can, and trying to enjoy this time with family under one roof.
Thank you all for coming on. I really appreciate this.
Thank you.
And so I wanted to allow you each an opportunity to make any kind of opening remarks that you wanted to offer. And maybe Deirdre, we can start with you.
Sure. So my remarks are going to be relatively short. So COVID-19 and racism are public health crises that unfortunately is not a part of the national conversation that should be had by the president and by the CDC. But thankfully, there are a lot of dedicated medical practitioners, clinicians, and public health officials who are really sounding the alarm. So we can see that there are two major organizations that have already declared racism as a public health crisis over the past 5 years, the American Academy of Pediatrics and also the American Public Health Association in 2015. This had always been on the radar of the federal government because in 1998, Surgeon General David Satcher created a national initiative to end racial and ethnic disparities by 2010. Unfortunately, that has not come to pass. But more recently, 3 cities in the industrial belt, Madison, Wisconsin, Milwaukee, Wisconsin, and Pittsburgh, have had city councils to declare racism as a public health crisis because of the social determinants that have made primarily African Americans and Latinx people more prone to certain conditions. Just recently, and that's a week ago, a Boston, Massachusetts city council person has also asked the city to consider this particular proposal. The issue, however, is that the Centers for Disease Control and Prevention, the CDC, has not declared racism as a public health crisis. In fact, they are not collecting data that deals with the race of COVID-19 patients. And so a big argument by public health officials, and I tend to agree with them, is that racism meets the 4 criteria set up by the CDC that determines a public health threat, right? Racism places a large burden on society in various ways. So that means medically, that means economically, and a number of other factors. Racism disproportionately affects a segment of the country's population. In my own work, I tend to focus on reproductive justice, reproductive health in this country's history. And so there are many ways that racism has disproportionately affected Black people. The US's current measurements are not enough to solve the crisis. Also, an expansive and coordinated public health approach is really needed to eliminate racism's negative effect on society. So in this particular case, the CDC is focused on coordinating public health strategies that don't necessarily speak to the particulars of what racism has wrought on society. And so even in looking at the current data, and much of these statistics are literally just a few days old on COVID-19's impact on Black communities, you'll see in many of the states that have large urban areas, particularly in the Midwest with Michigan, Illinois, and Wisconsin, you see the number of COVID-19 cases with Black folk. So literally Black people make up in Michigan 15% of the state's population, 35% of COVID-19 cases. In Illinois, 16% of the population, 30%. So almost double. North Carolina and South Carolina, they're part of the traditional Black Belt, southern states that have pretty large Black populations. You can see that the number of COVID-19 cases outpaces that. What's really interesting though about Milwaukee, Wisconsin, you see that 45% of patients who tested positive for COVID-19 are Black people. There is a Black county population of 26%. Now, what was really interesting for me, excuse me, is not simply that these states have significant number of Black COVID-19 patients, but in Michigan and Illinois alone, in Wisconsin, they rank as some of the worst states to live in as a Black person. And these are stats that have been culled from November 2019. So just a few months ago. Michigan alone has 2 cities, Jackson, which ranks as number 13, Niles, Benton Harbor is number 6 for worst cities for Black people to live in. Illinois has 5 of them, from Peoria, Danville, Springfield, Rockford, Kankakee. Wisconsin, Minneapolis, St. Paul, Bloomington are all ranked at, and Racine, number 2, Milwaukee is number 1. And so we know with the large numbers of Black people who live in the South, who have migrated to the South in a kind of reverse Great Migration over the last 10 to 20 years, the impact is going to be significant. We can already see the stats that are happening in New Orleans and in Louisiana. And today, according to the New York Post, the death rates in New Orleans have now surpassed New York in terms of proportionality.
Sam, I wanted to know if you had any opening thoughts.
Yes, thank you very much. It's great to be here and to join you all in this conversation. I don't have visual aids, but have been thinking a bit about this as this has been unfolding. It's kind of like a fast motion drama in which about every 12 hours there's something new happening, and it changes, regularly changes what it means for our communities, for Black communities. Thinking about when these things happen, I tend to take the long historical view on them, which I think has the benefit of keeping things in a certain perspective, but then it also has the drawback of, kind of waiting to see what this is about. And this clearly is a crisis, and it's a bit unnerving to lose that context as this unfolds. But there are a few things that I think have emerged, certainly that we'll have to discuss over the next several years in the wake of COVID-19. One is that I think once the crisis itself passes, and it will, with any luck, we'll flatten the curve, minimize the destruction, and get to a point where everyone will have some sort of developed immunity, either through having acquired the virus and survived, or through a vaccination, which is not to be on the horizon for at least for 12 or 18 months. But then therein lies the danger, where it'll be very easy, I think, for us in a national conversation to think, well, we survived this one, we conquered it, et cetera, and then we need no longer think about it. And from my point of view, thinking historically, COVID-19 is really enjoins us to think about what it says to us about structural inequality. In a lot of ways, I think, despite our reaction in terms of being in crisis mode, I think COVID-19 is more or less going to be a new normal. We've had about 4 of these in this century. SARS and MERS are in the same family as COVID-19, and then H1N1 being in a different viral family, but still at least some similar etiologies and modes of transmission. That should let us know that this is something that we're going to be dealing with for, barring innovations in genetic medicine and, viral engineering, probably for several decades to come. In which case, we need to think about how our health infrastructure, really that means the built environment of our communities and how we mitigate social inequality will help us prepare for the next acute respiratory pandemic. So in a lot of ways, and this is again thinking more academically, which I know is tough to do given the fear and anxiety this causes all of us at this moment. But I guess I'm trying to think of what happens after we flatten the curve. And once we've gotten over the curve, how do what's the wrap up afterwards? And I think we can think of COVID-19, like so many other diseases, as being a litmus test or reactive agent test for the structure of our society, which is to say the structural inequalities and structural vulnerabilities. And we can think in terms of the ones that affect our communities most prominently. We could think, of course, of mass incarceration, right? First of all, economic precarity, and then also maybe just a basket that we can put a lot of things into, which we'll just call medical and public health neglect. In terms of mass incarceration, we've known for a while that that mass incarceration itself is deleterious, not just to our incarcerated family members and community members, but also for all of our communities. That everybody, most people come home. And cycling in and out of these institutions, which are, in such as institutional health assaults, is not good for them and for our communities. Here in New York, we saw our first incarcerated person die of COVID-19 at the end of last month, March 30th. A man who was age 58, Juan Mosquero, at Sing Sing prison. 58. We're more or less all of us, I think, are of the same generation, but I'll speak for myself. For those of us who are rapidly approaching that number, we don't tend to think of that as being particularly old. It's not particularly young either. But in a carceral setting, 58 is quite old. Depending on how long you've been there, being incarcerated can age you by anywhere from 10 to 20 years. And so we need to think about what this means for our elder population, many of whom have been there because of so-called sentencing reform since the 1980s and 1990s, under both Reagan, Bush 1, and Bill Clinton. And here, and as in states and city municipalities across the nation, we are dealing with these effects and also trying to mount a pressure effort to get our leaders to release people. Compassionate release is something that's on the books for every parole board and every correctional board in all of the states. It is there to be availed by members of our executive government, and we're just waiting for them, mayors and governors alike. And prisons themselves, as I said, are not places of good health treatment, let alone, of course, the promotion of just daily healthful living. And we've known this because of high rates of historically HIV, of mental health disturbances. Some of us may remember, about not too long ago, about 20, 25 years ago, that there was a national epidemic of tuberculosis in a lot of our carceral settings, which is still endemic in many of them. All of these are parts of the social environments of prisons themselves and the political environment of the carceral state. There's also outside the walls what is happening in our communities. It is a real, a rank tragedy that among the most predisposing conditions for contraction and serious suffering from the virus are asthma, diabetes, heart disease, and hypertension. All four of which you will find in great abundance in our communities, and they're ensconced there, like for quite some time. This has been the problem, and these have been from economic and political factors compounded over years and years and years. Black communities are also structurally vulnerable. Particularly in our cities, we're living more densely because of the vicissitudes of, in most places, a largely open market, free capitalist housing market. And this is just from assaults on public housing since the 1970s and 80s. And don't let any kind of discussions in any given city, mine included, unfortunately, of efforts of affordable housing. Those are to be lauded, but they've never met the demand in pretty much any city of which I'm aware in this country anyway. Not surprisingly, housing insecurity and homelessness has been an ensconced problem for our communities as well. And here we must remind ourselves that homelessness is not the age-old image of people living on the street. Housing insecurity is somebody who's been crashing on a friend or neighbor's or relative's couch for weeks at a time. Also adding to the burden of housing, crowding, other things. We are also less able to afford to shelter in place, as the phrase is today. More of us work in low status health workers, which makes, obviously, if you're a health worker in a crisis like this, you are called to duty. But quite often not at the rate of remuneration that maybe some more well-paid physicians are. I'm talking about our home health aides. Largely women who work in these, but men as well who work as home health aides, as hospital orderlies, medical technicians, the whole like. People tend to think of our medical infrastructure as being doctors and nurses, forgetting that they're actually a minority of what makes our system work. And those are good jobs when you have the protections, which our medical staff haven't been getting. And then there's pre-existing environmental assaults, lack of clean water. Michigan, as Professor Cooper Owens just mentioned, is a high-ranking state for Black morbidity and mortality. And that's not unconnected to a water crisis that's going on 3 or 4 years now. That's just, basic, not having access to clean water predisposes you to a whole host of infectious and gastrointestinal diseases. So it's not unconnected to that. We suffer airborne pollutants and food justice issues as well. Just as in some concluding thoughts about how we collect the data for this. Right now, very few of our municipalities and states, as Dr. Cooper Owens just mentioned, are collecting data based on ethnicity or what many of us call race. That itself is a problem, but I would also, as we move forward to press for that kind of data collection, we need to make sure that we have it properly indexed and cross-referenced with zip code and geospatial data as well, because it's very easy. It's very easy to have. We see this historically when we collect data, disease data, surveillance data on ethnic populations. It's easily translated in popular parlance and even on professional amongst our our public health class to morph into a politics of stigma and blaming. What we really need to point out is that racial inequalities and disparities in COVID-19 infections are about the structural inequalities of our built environments. It's not about quote unquote race itself. It's about racism. And so we need to be very careful that as we ask our leaderships to collect this data, that they consult with people who collect the data in their health departments and cross-index it, which is not difficult to do in the era of big data. And just looking back, if you look at some of the morbidity and mortality data from lower respiratory infections from about 5 or 6 years ago, and this kind of proves the point. We see the hot spots for those infections were mainly in the Southeast, from about basically up, southern North Carolina all the way down into West Texas were the main parts. And then parts of Appalachia as well, Rust Belt cities as well. And I don't think this is a mistake. These are places where we find fraying public health infrastructures, where we find high rates of poverty and inequality, and of course it's where we find high proportions of African Americans as well. So I think that data shows us what we can expect as the epidemic moves from New York City, and then when it takes hold in the South and the Southwest is where we'll really see how unequal our health infrastructure is. So I'll leave it there and look forward to the discussion. Thank you.
Thank you, Sam, for that. And Ruha, any opening comments you'd want to give?
Yes, please. I'm going to switch over to my slides now. And I should say that until Professor Minkah Makalani invited me to the conversation, I didn't think I had that much to say, and I told him as much. And then when I started thinking, the thoughts started rolling out. So I've titled my reflections, Stayin' Alive, but also Stayin' Alive. And I'll start with something that may seem unimportant. Rona, this nickname for a ravaging virus, is itself, I think, worthy of a little reflection. It's playful and ironic. It speaks to the relationship we have or are trying to create with something that threatens us. Nicknames, after all, have a social function. They reflect and reinforce different kinds of intimacy with whomever or whatever we've renamed. So Rona communicates an insider relationship. It says that I don't have to call you by your government name, but Rona instead. So what does all this mean to have an intimate relationship with a deadly pathogen? For starters, I think it means that many of us know death intimately. It means that many of you already have family members and friends directly impacted by the virus. On a personal note, it means that in 2014, my dad died in a hospital room in Cedars-Sinai Hospital in LA because he was infected with Rona's distant cousin, H1N1. It means that although Rona might have global notoriety, we're going to have to bring it back down to earth because it could just as well show up in our backyards, in our living rooms, in our lungs, and we want to be ready. So Rona is a way of exercising a little bit of agency by renaming, even as we take seriously the devastation on families and communities. It's a way of staying alive, but also staying alive, a point I'll return to in just a moment. But first, in a recent essay titled The Pandemic as Portal, one of my favorite writers and thinkers, Arundhati Roy, concludes, historically, pandemics have forced humans to break with the past and imagine their world anew. This one is no different. It's a portal, a gateway between one world and the next. We can choose to walk through it, dragging the carcasses of our prejudice and hatred, our avarice, our data banks and dead ideas, our dead rivers and smoky skies behind us. Or we can walk through lightly, with little luggage, ready to imagine another world and ready to fight for it. Or in the words of Erykah Badu, let it go, let it go, let it go. And while Roy's portal directs us forward with a choice between business as usual or a more just and joyous world, portals can also lead us back in time, allowing us to reflect on where we've been and what we've accepted as normal and inevitable, all that kills us slowly, needlessly. The spread of a microscopic virus, in short, puts our business as usual under the microscope. Even everyday attempts to protect ourselves from infection are not immune from racism. Exhibit A. In the last few weeks, many people in the US are playing catch up with the common practice of public mask wearing that's already common in other nations. In our case, since personal protective equipment is still in dangerously short supply for health workers, we're being encouraged to wear homemade masks when in public. So there are now Instagram and YouTube tutorials which require only a bandana and 2 hair ties in some cases, or you can get fancy and go to any one of some online vendors with many different styles to choose from, including kid sizes. There are even face guards you can assemble in a few easy steps. Here's my favorite tutorial created by architectural designer Amina Blacksher, who, you have to admit, looks like the main character in an Octavia Butler novel right here. At least the future is fly. But as I said, even these everyday attempts to protect ourselves from viral infection are not immune from racism. Because you may be wearing a mask for safety and solidarity, but your Blackness may still be a threat. As Aaron Thomas reflected, I don't feel safe wearing a handkerchief or something else that isn't clearly a protective mask covering my face to the store because I'm a Black man living in this world. I want to stay alive, but I also want to stay alive. This is the fundamental tension, isn't it? Staying alive, but also staying alive. Black people are not only trying to survive the pandemic, but also the many social threats that exist. Indeed, focusing only on Rona by wearing a homemade mask to the store, for instance, could leave you shot dead in the aisle. It's happened too many times before and before and before. I couldn't help pointing out briefly that masks figure prominently in Black studies more broadly. When Baldwin writes, "Love takes off the masks that we fear we cannot live without and know we cannot live within. Literal and figurative forms of masking converge." The fact that surviving white supremacy has often entailed wearing masks in the Fanonian sense of Black skin white masks, symbolic coverings that attempt to shield the mask wearer from an oppressive gaze. This is some of what the pandemic as portal reveals, that for many people, putting on a mask before you leave the house has long been a way to survive social threats in white schools, in white workplaces, in white space. So as we reflect on this unprecedented moment in the life of the planet, I think the only way we can forge a more livable world amidst the ruins of the old is if we reckon honestly with how white supremacy, class oppression, patriarchy, imperialism, and more have wreaked havoc on people's lives well before Rona. We've all heard or seen the public health catchphrase, "Viruses don't discriminate and neither should we." Yes and no. As an aspirational slogan, I appreciate how this speaks to the renewed racism and xenophobia we're witnessing, from Trump's Chinese virus to the verbal harassment, denial of services, and physical attacks directed at Asian Americans. But as a soundbite, the idea that viruses don't discriminate also conceals the fact that Rona is not simply a biological entity, but a biopolitical reality, which travels along well-worn patterns of inequity that are slowly coming to light. Exhibit B, headlines such as Black people make up 50% of COVID-19 deaths in Michigan. Early data shows African Americans have contracted and died of coronavirus at an alarming rate. Wealthy LA areas have higher rates of coronavirus cases. Why those numbers are deceiving. Why people should stop joking that Black people are immune to coronavirus. Or as another writer put it, our immunity is as fictional as Wakanda. Taken together, one message is clear. No, the coronavirus is not the great equalizer. But there's another message that can get lost in these headlines. These disparities in contracting and dying from the virus are not simply the result of pre-existing conditions, some inherent vulnerability of Black bodies. Sure, underlying chronic health issues such as diabetes, hypertension, asthma, and heart disease make people more vulnerable. But why do we have these higher rates in the first place? To speak only of pre-existing biological conditions is to normalize and naturalize Black death. So we have to be clear when we speak to also name pre-existing social conditions in housing, employment, education, mass incarceration, and healthcare that impact communities well before Rona showed up, and as which my co-panelists have already pointed out. Conditions that ensure that poor and racialized people are less likely to get tested, more likely to be turned away with symptoms, less likely to have insurance coverage, more likely to be working in low-paying but essential jobs, less likely to have the option of sheltering in place, more likely to live near heavy air pollution, making them more vulnerable to respiratory disease, less likely to have paid sick leave, more likely to experience plumbing poverty with no access to running water to wash hands, less likely to have savings that can carry them through unemployment, and more likely to die. In short, the pre-existing social conditions of the nation, not simply the pre-existing health conditions of individuals, is what we have to draw attention to. The virus is not simply biological, but biopolitical. It may not set out to discriminate, but the structures in which it circulates certainly do. If racism is, as Ruth Wilson Gilmore describes, the state-sanctioned and extra-legal production and exploitation of group-differentiated vulnerability to premature death, Rona is surely taking advantage. But perhaps even worse, the very people who we might turn to mitigate this crisis are instead taking advantage of these vulnerabilities in some cases. Exhibit C. In an interview last week, French scientists had the audacity to suggest on live TV that a coronavirus vaccine should be tested on Africans, reminding us of the routine scientific experimentation and exploitation of Black people in the US and globally. What's more, the very people who we would turn to administer policies to safeguard the health of our communities are in some cases employing predictable forms of racial profiling. The first person in Britain to be arrested and convicted under the Coronavirus Act is a Black woman, Maria Dino, pictured here. She was arrested and fined for failing to provide identity or reasons for travel to police and failing to comply with requirements which authorities now admit were bogus charges. Indeed, the vast public health surveillance structures being rolled out will likely rest on forms of containment and punishment that already target racialized people, not inevitably, but predictably. So if the pandemic is a portal, in what direction do we want to go? Perhaps one that entails what Christina Sharpe describes as, is solidarity the right word? I'm not sure. Nonetheless, distributed risk. It has been about risk for some time. It has. We must distribute it, she says. I don't know exactly what that looks like. Maybe everyone has to take a 2-week turn to do farm work, to stock grocery shelves, clean public space, learn triage, deliver food. As I say, I do not know what forms of solidarity will look like. I do know we must imagine them. I do know it is untenable to keep one portion of the population to risk their lives so that another portion of the population can stay inside and lessen their risk. They must be paid and protected, and they must not be allowed to be the only ones to take the risk. So if the pandemic is a portal where risk and thereby safety is redistributed, then can we also imagine joy and mutual aid proliferating? Shout out to all the mutual aid collectives out there, the New York City Black Folk Mutual Aid Fund and the Mutual Aid for People Impacted by Incarceration, among many, many others around the country and world. And as one writer observes about the quarantine clubs on Instagram Live, where DJs like D-Nice and Questlove serenade hundreds of thousands of listeners across the globe, you have to be there in the moment, to dance in a time of uncertainty, to feel free when so much of life has been shackled, and to be happy during a year that has produced a surplus of heartbreak. So from where I sit, this is an insurgent, stubborn joyfulness that isn't simply walking through this pandemic portal, but dancing, clawing, crawling, if we have to, through this virus-infected landscape to something new. To that end, we need to also take some pragmatic action. So I encourage everyone to visit thepeoplesbailout.org for one way to get involved. As the website states, we need a swift, inclusive bailout by and for the people. As nurses and grocery store clerks keep the country running, Congress is developing a relief and recovery package to address the effects of the COVID-19 pandemic. Policymakers and administration have put forward plans that attempt to return the economy back to a status quo where safety and security are promised only to corporations and the wealthy few, gambling trillions of tax dollars on stimulating the stock market can't fix the shortage of hospital beds or the pollution in our skies. Only workers can. So in this moment of crisis, the website says we need to change the rules. Let's pull together, as we've done in times past, to demand our government provides money and care to those who are hardest hit by this crisis. So I encourage you to visit the bailout. In conclusion, I'll end where I started with Roy's essay, in which she says, nothing could be worse than a return to normality. Thank you.
Thank you for that. And now I want to kind of open the conversation up a little bit. So, and listening to your comments and thinking about everything that's going on more generally, I was struck by one, how a lot of what you all are saying really overlaps and kind of builds on one another in some interesting ways, particularly for me, someone who's not very versed in the field. But what I am struck by initially is, Deirdre, your point about racism as a public health crisis. And so the CDC's failure to declare it as such, but the ways that it meets this criteria. And thinking about what that means for understanding the experiences of people of color, but Black people in particular. And then, Sam, to think about your point that COVID-19 for the next couple of decades probably will be this, as you put it, this reactive agent test for assessing health infrastructure in our community.
Just to be clear, I wasn't saying COVID-19, but just severe respiratory syndromes will be.
Okay.
I mean, once we have a vaccination for COVID-19, ideally we'll consign it to the dustbin of history. That probably won't be the case, but that's the goal. But then what I'm saying is that something else will come around, and that these emerge because of our social organizations.
And so
I can edit that part out.
So no. I mean, that's a good correct. This is why I have you guys here to talk about it, and not myself. But just that the way that these two things kind of link up, that this isn't something that begins. It didn't begin now, obviously, but it's certainly not going to end if we just continue on as things have gone up until this point. So how do we approach this issue of this public health crisis that manifests itself in terms of health and community infrastructure, respiratory conditions, the number of things that you pointed out, both a couple of you, in terms of housing, education, mass incarceration, pre-existing conditions like asthma, diabetes, hypertension. So how do we think about these in both this moment and then moving forward, if we're thinking about your comments, Ruha, in terms of not returning to normality, as Roy had said?
I think I'll take a stab at it because I tend to focus my work, at least a lot of the advocacy work on reproductive justice and birthing justice issues. A part of the framework for reproductive justice is about access, right? It doesn't necessarily prioritize choice. And in a very personal way, I grew up in spaces that had been almost predominantly Black. So growing up as an elementary kid and teenager in Washington, D.C., Southeast, and then moving one of the poorest in South Carolina, Williamsburg County, and recognizing that access is really important because sometimes there just isn't an infrastructure that is had. So for instance, in a lot of rural spaces, especially in the South, where Black people have been in those exact locations, their ancestors, descendants for centuries, there are often not hospitals. Right? There is no statistical data that is compiled in those places because the populations continue to dwindle, but also there just isn't money. And so even if one wanted to have access to testing in rural spaces, they just don't exist. And so, to kind of harken back to what Ruha offered us based on the Roy quote, we don't want to turn to that kind of normalcy, right? That normality, because the structural foundation just isn't. They're just about racism as a public health crisis, but it's the kind of economic inequality that exists in places like West Virginia, where you have large populations of intergenerational wealth with white people who live in hollers, where sometimes they don't even have a connection to government agencies. I mean, not even having Social Security numbers. Those are people who are literally living in the midst of fracking, right, and drinking unclean water. But we often only hear about Flint, Michigan, right, because it's a city. And so for me, there really is this divide that happens with rural populations who are left out of our urban areas. So it is dangerous in some cases to be in those remote areas, in those rural areas, because you don't even have hospitals that are brick and mortar structures. They're being treated in mobile units, right? Where I'm from in South Carolina, we haven't had a maternity ward since 1990. And because of the current tropical storms and hurricanes that happen, many of the services are being done in mobile units, and that has gone on for decades.
So the question of, not returning to what was normal, because I'm struck by this asinine claim that Trump started spinning out, that the cure cannot be worse than the cause. And the focus, as far as I can tell, is solely on the economy and trying to shore up his standing where he thinks his reelectability kind of lies. And the thing that struck me about that is it reeks of a crass economic or crass calculus of what is an acceptable number of death versus maintaining my position in power as is tied to the economy. But there seem to be all these other elements to that, these other factors into that cold calculus that for me just rang out. Black people can die, poor people can die, and if they are the bulk of that 100 to 250,000 that die, what can we draw on to help us think about ways that we don't return to what is normal?
I mean, one of the heartening things that I've observed over the last few weeks even, is that people's ability to really cut through the rhetoric in terms of public discourse and our collective conversations, really sort of cutting through that collective we, that when the president speaks or when many different officials speak, that they're not articulating the experience that many people are having, where you can be both essential and disposable at the same time. That sort of tension is really coming to light. So in the last few weeks, when we've seen different worker strikes, especially in the gig economy, where the grocery store workers and many people who are doing this essential labor, it's crystal clear that people are relying on them, and then withholding that labor, where you can't easily now go to your app and order those groceries so easily. And I think just seeing that, as one of the strategies in order to push the policy to match the rhetoric of that collective we, in terms of all of the different kinds of work that now is required, low paying, disposable but essential. And so just thinking about taking that organizing to the next level, I think is one of the more pragmatic ways that I think about your question.
I think that there's also ways in which certainly the current occupant of the Oval Office bears more than his fair share of blame for this. But I think there's also a longer term lack of public health preparedness, and also really more importantly, a lack of orientation of how we think about what public health is. That we just as a country, meaning our leadership, but also many of our public health leadership as well, I think they have to take some of the blame. We've not done a good job of thinking about how health should be a right. And I'm not speaking of health care, which I also is a right, but a right to health itself, which is different from health care. Then also how certain disease actually, as I said earlier, are the reactive agent test for how much inequality you have in a society. Our response to HIV after 1981 was first complete ignorance, and stigma. And then it was about outreach to focus on people's individual behaviors. And it was many years before in our, the research cadre, we understood that there are dimensions of HIV that show structural inequality. When HIV appeared in South Africa, in South Asia, and in Brazil, we started to really put, this isn't something you get rid of by telling people to protect themselves. That structural inequality is the fundamental cause of disparities in HIV infection and AIDS deaths as well. But yet we always forget those lessons from the 90s as we've moved into the 21st century. I think that's where a post-COVID-19 direction should be laid for us. Because it'll be very easy for us once we get over this, and we will, until the next one happens, to kind of go back to business as normal, to act like we still live in a post-microbial society like we did, in the 1960s or 1970s. Like we've still forgotten that there was about maybe 3 or 4 decades when humanity wasn't plagued by infectious disease. From like the 1940s until HIV. But we're back to the normal that we had for thousands of years now. And we're not doing a good job of adapting our political culture to that.
Right. And, the one of the things you had said as well, Sam, earlier, you had there are 2 things that all of your comments just made me think about. One is the relationship between mass incarceration and the communities and what people are returning to, and that this isn't, at least what I took from you, if you didn't actually say this, that it isn't simply an issue of how we think about it in this context, but longer standing problems with reintegration of people into communities, structures that are there, but then this exacerbating some of those problems that already exist. But then Ruha, one of the things that his comments made me think about was that story from the French doctors wanting to test on Africans. And I automatically started thinking about your work, Deirdre, and how it's kind of unpacking this complex history, this racialized history of gynecology. And I begin to wonder, this all to say that this isn't something that is even recent in terms of just this century. This is something that is actually centuries long. But how do we then confront that moving forward? How do we, what is that imaginative, the policy issues that we maybe need to think about? And then, what are some realms that we maybe need to go beyond what policy can offer us, and maybe even beyond what we can imagine, which is much more difficult thing to kind of get at. But, how do we approach this without giving into a sort of pessimism and resignation that this is just what it is and this is how it's going to be? How do we, what mechanisms, what institutions are in place that can help us move forward, particularly if we can accept that we aren't going to be at the behest of social distancing forever, that this will end, but how do we then approach the next crisis? Or maybe to your point, Sam, how do we approach these longstanding structures that get us from crisis to crisis?
Mm-hmm. Yeah, that's interesting. I mean, there's so many ways to answer your question, and thoughts are kind of swirling here. I always consider the role of the historian as a griot. We are the ones who are always kind of recalling to those who are present about what has happened to us in the past, right? So as I thought about those doctors in France who on not just national TV, but international TV stated that Africa should serve as a laboratory of sorts, and Africans as essentially guinea pigs and lab rats. It made me think to Georges Cuvier, the famed French natural historian and scientist who continued to work on Saartjie Baartman's body, right, after death, and what that meant, right? And he lays a template for people, white men, particularly throughout the Western world, for how to treat, think about, write about, examine Black bodies, right, across the Atlantic world. And so you're right, none of this is new, none of this is exceptional. So what we have to do is be in work in concert with various kinds of people. So from artists to scholars, activists, medical practitioners, and we need to be on the same page. And so for me, the way I kind of stay in my lane is to continue to push the agenda of how do I change medical knowledge, right? I did an interview just last week with a Turkish station, because in that country, they were combating these stereotypes about Black people being immune. When I'm doing work about maternal morbidity and infant mortality with Black birthing people, Black women, and children in this country, I am continuing to transform medical education through curriculum development with med schools and nursing schools, right? And then you have a lot of Black women who are now in elected positions nationally. Ayanna Pressley, Representative Alma Adams out of North Carolina, she was a former professor of mine at Bennett College, who are making sure that the Senate, both the House and the Senate, are being inundated, right, with public health policy measures that are correlated to the kind of anti-Blackness, right, the kind of racism that we are experiencing every day. And so for me, I often smile when I see a newspaper like USA Today that has these kinds of stories on the front page, right, because that means the message is getting out. And so it's going to be a slow trek, but I think if we just keep kind of beating the drum and sounding the alarm, that eventually something is going to stick. And so people are reacting in the ways I think that they can control. So when Ruha mentioned D Nice, right? From my perspective, I'm like, oh, this is music therapy, right? Therapy. And he's not a trained doctor or clinician, but he's taking his skill set to a group of people who are living through a global pandemic and curing us in that present moment of our own trauma, depression, medical narratives. So people on Facebook talking about the ways that this pandemic has affected them emotionally, psychologically, financially. For me, that comes out of the Columbia University School of Medical Narratives, right? And how this is really important. And so even if we don't apply those kind of jargon labels, those kinds of, academic sounding terms to it, people are healing each other, I think, in the kind of communal ways that have always worked. And so I'm a big proponent of participating in that, but also advocating that others participate in that as well.
Mm-hmm. Deirdre, as always, you left us with about 5 or 6 jewels there, and I had I had responses to all of them, and then as you went to the next one, it dropped out of my head here. So I'm just kind of thinking here. Thank you so much for that.
Yeah.
And the other thing about, and Ruha, thank you for, because I missed that story about the French physicians.
I
so
had to
look that up. And thank you for bringing that to all of our attention. But there's something else about that statement too, that it completely occludes the fact that the African continent has been a laboratory for decades.
There are whole books written with that exact title.
Exactly, right. Yeah. And not just a medical and scientific laboratory, right? It's been a policy library for all manner of austerity schemes. And it's like this kind of repeated, decade, generation after generation, this implication that colored people need to, do their fair share. They need to pull their own weight, like you need to contribute to the effort by literally giving up your bodies. It's just such a rank ignorance of the historical fact.
And I think, one of the things to point out for those who then go and look this up, one thing that's really striking is literally as it's happening, as it's coming out of the mouths of these French scientists, people around the world are responding. And many African scientists, researchers, public health professionals, activists, within the minutes of it happening and emphatically refuting it. So, it's the same, but the way in which our sort of collective response and understanding of how something that seems so, just in passing, few words, the stakes of that idea that Africa could serve as a laboratory is completely refuted as it's happening. And so I think that's we can take some heart in terms of our collective awakening to that kind of, that kind of ideology that gets then embedded in policy that people are not just taking it anymore. Not that they ever did, but now we can hear the expression from the people who are most affected, refuting it in real time.
Yeah, absolutely.
Yeah, it's so funny. I think Rwanda's public health response was to immediately bring mobile sinks, right, so people could wash their hands. Nigeria literally they have cured those 2 COVID-19 patients that they had. This is one of the most populous nations in the world, not just the continent. And so Africa has always stood at the forefront of knowing how to deal with pandemics in ways that European nations have not, in terms of the ways that the United States has not, even with all of our resources. And so it is interesting to me, these 2 French scientists, and France is dealing with a disproportionately high number of cases, are going to say to a continent, right, that they need to be, and Africa is not dealing with it in the numbers, right, the cases, in the same ways that Western nations are. And so in many ways, it's almost laughable, because it is so, it's absurd in many ways, right? If they actually look at the numbers and the public health responses, even by some of those countries who have economies that have been, and excuse the ableist language, but quite literally crippled, right, by Western intervention. And so I just kind of laughed when I saw that news story with the French scientists, because I knew Black Twitter was going to tear them up.
Yeah, and I haven't seen it. This was the first that I had heard about it, but it just strikes me, kind of to your points, that it doesn't occur to them to look and see what is happening in various African countries, that how are they responding, and how might that be instructive, which just shows kind of a lack of imagination, if you will. And maybe in some ways, the normal course of things. This is the very thing that we're talking about not returning to. And yeah, it's heartening to hear you all talk about these things and to help put it in a broader historical, but also social and political and cultural perspective. Particularly the idea of how we name it and how that allows us to think about and access both one another and our relationship to both the state, but also the virus itself. And I want to just offer you each a couple of minutes, if you want, to just say something in concluding as we close out the conversation.
Yeah, I was thinking about the one of the threads running through our conversation about the importance and the care that we take in framing the various layers of the problem, in naming what it is we're trying to fix and solve and cure. Mm-hmm. And one of the studies that came to mind was some researchers out at Stanford were looking in a completely different context, not public health, but looking at mass incarceration. And their study, which I believe the main title is "The Numbers Don't Speak for Themselves." And so when we're talking about data collection, specifically the rate at which Black people are contracting coronavirus and dying from it, I think we have to put as much care in terms of producing the data and also narrating the meaning of that data. And so one of the takeaways from this particular study is that the researchers presented white Americans with statistics about the overrepresentation of Black people in our jails and prisons. And they approached people coming off the BART in San Francisco and on the street in New York. In San Francisco, they showed them data and then asked if they would be willing, seeing the overrepresentation, to support policies that would address the 3 strikes law in California. In New York, it was stop and frisk. And what was interesting was that the more that data that they were exposed to about the overrepresentation of Black people in our jails and prisons, the less likely they were to support reforms to this punishment apparatus. And so our kind of enlightenment thinking says with the more data, the more understanding, the more statistics, then we're going to act on it in the way that we hope people would act on it, which is change the structural, situation that leads to that. But what we often have to remember is that there are stories that people tell themselves about the data that they're seeing, why that overrepresentation exists. We can call these conceptual lenses. We can, just talk about the way in which, for example, you might see that overrepresentation and say, well, maybe they're more crimogenic. Maybe they're more prone to X, Y, and Z. And you can think about it as an inherited disposition towards crime that leads to that. And so what I want to encourage us to do is, in our calls for more data around the risks associated with the virus, to understand that the data will not speak for themselves, that we have to put just as much care into really shaping the stories that we tell so that it leads to the right policy responses, so that people don't just assume, well, you're dying more because you're just more sickly, or maybe you just have some genetic predisposition to X, Y, and Z, rather than thinking about these layers of structural inequality that makes it almost inevitable that we would see these outcomes.
Again, I'm left thinking and just going in so many different directions. Thank you for that, Ruha, because the narrative is absolutely important. In the discussion now about collecting, quote unquote, racialized data or racial data, it could easily just go where it just becomes stigma, like just part of a narrative of stigma, which is why we need to think of it in a greater context. I would say also maybe part of that framing is that we really need to think about our ethics as well. And there's a little bit of discussion about this online about how do we conduct ourselves ethically in the midst of a pandemic. And most of those are about individual ethics, unfortunately. But we need to think about what are the ethics of an unprepared, an unprepared public health infrastructure, but also the ethics of how we've neglected communities of color, under-resourced communities in terms of basic things like education, access to water, access to health and to health care. And I think that needs to be also part of the discussion so that we could at least have some sort of larger discourse about what do we actually think is right and wrong. And that goes all the way down to the discussion of, like how much essential service do you actually need? We still have an issue here in New York. It's better today than it was about a week ago. But there were issues of, like people who would run to the grocery store all the time instead of keeping a list and going as seldom as you can, so that you're not taxing resources that, other people could be using. Trying to avoid using delivery services. If you think you are able to protect yourself, because there's many people out there who are not able to protect themselves, including the person who does the delivery. And these are things, I think these are ethical conversations. I'm not a bioethicist. I'm calling for, a fourth or fifth person to be on this panel, I guess. But I think it's really important because we don't really have a North Star for that, how we think about this in terms of what's our justice ethic.
I thank you both for that. And to kind of continue the thread of the narrative, in some ways, I'm approaching it kind of oppositionally. So I have been heavily involved with what I call kind of old people's social media, which is Facebook. And so I am constantly observing conversations that are happening with many of my academic friends, and then those folk who are outside of the academy who are also engaged in these conversations. And so what I'm seeing, and not with everyone, but a small minority of folk, they are tired of Black people being the face of oppression. And so they're like, why are you, being instruments of white supremacists and trying to make novel coronavirus or COVID-19, right? Trying to make Black people the face or the symbols of this. And so in those conversations, I learned something, right? I used to be a fourth grade teacher in Atlanta. So I know all about teaching deductive reasoning. Deductive reasoning is sometimes not being employed in certain places because people are thinking about raw numbers as opposed to disproportionality. And so this is where I think all of us who are educators, and particularly those of us who've been trained in disciplines where context is really important, being able to teach context in a way that is respectful and not condescending, but also to let folk know it's not about this kind of politics of respectability where Black people always have to be triumphant, But when we think about the kind of social determinants of a structural system of oppression, which is anti-Black racism, which is white supremacy and white nationalism, Black people, brown people, I mean, we can go down the list, right? Elderly people, those who are ill, those who are gay or queer, we are always going to be on the short end of the stick, right? In terms of the things that we receive, but also the things that assault us. And so just because you want a kind of triumphant narrative around Black people's, innate ability to fight off and ward off this virus because of our melanin, the real truth is the social determinants that have been instituted in this country for centuries are the things that are making novel coronavirus and COVID-19 a Black disease, a poor disease. Because Sam brings up a really important point, right? The very people that we tend to ostracize, we tend to critique them for not having multiple streams of income, are those who are working in fast food, working in restaurants. They're the delivery people. They are now considered valuable, essential employees, but are not even having the ability to access hazard pay, double overtime, right? And so we are literally having people who don't have access to personal protective equipment to come into our homes. And so, and those people tend to be Black and brown and mainly women and the working poor. And so all of these things for me have been really great teaching tools when I can go and speak to folk who make these kinds of claims about not wanting to have Black people be the symbols of this disease, but to be able to talk to them in a respectful way as someone who has a little bit more knowledge, and to at least get them to understand context, that we're not talking raw data here, right? Of course, we live in a country where there are more white people, and so they're going to have the greatest numbers. But when we think about statistics and ratios and proportionality and disproportionality, you're going to have poor people, those with those existing conditions, and also Black people, unfortunately, who will start to typify positive COVID-19 cases, but also deaths. And so that's important to also kind of be conscious of the oppositional narrative that is coming from some members of our community who are just tired of seeing Black people as everything that's bad.
All right. Well, again, I want to thank all three of you for coming on, sharing your knowledge, wisdom, perspectives. And I hope to see you all very soon on the other side of this. Hugs and high fives when it happens.
All right.
Thank you, Dr. Makalani.